board with Eric and with my husband Larry and many others. And we are together coordinating our education events tonight. So, Larry, do you want to just at least say hello? He'll be recording or monitoring the chat.
Hi, I'll be checking the chat. Also, a Blue Mountain Ski Patroller and a member of the Bear Creek board, and looking forward to this presentation. We've worked with David in the past in wilderness medicine and really enjoy his presentations. So, um, Eric had a couple of comments about not being the QR code not working.
Okay, yeah, I was able to get it to work, but
Right. I will be sending the link in, so just give me one second.
yeah, there'll be an alternative way to log in if you can't get the QR code to load. So without further ado, it really gives me a lot of pleasure to introduce David Fifer. I know David through the Appalachian Center for Wilderness Medicine. We've taught together advanced wilderness life support in some wilderness locales, and he's really a great person and has amazing experience. So let me give you a formal introduction, David. He is an associate professor in emergency medical care at Eastern Kentucky University. David's been an EMS provider since 2001. Prior to joining the EKU faculty, David served as a professional field provider and firefighter in Virginia, Kentucky, and Washington, D.C. He has experience as a ground search and high-angle rope technician for SAR teams in Virginia and Kentucky. He is a helicopter hoist rescue specialist for Kentucky State Police Air Rescue and the manager of the Kentucky Urban Search and Rescue Heloaquatic rescue team. So, David, that doesn't even begin to say all the things that I know that you're involved in. It's a very long list. So I'll turn it over to you.
All right. Well, thank you. Yeah, I think probably the biggest reason that I am involved in so many things is that I chose to be a paramedic. So I gotta make the ends meet. I have to have like 20 jobs. I should have been a PA or something like that, right? But no, a lot of those things that you mentioned, Linda, are sort of fractional aspects of my time. And so I wear a few hats, but really what I do full time is teach EMS, teach wilderness medicine. So happy to be doing that tonight. And I have two alibis. The first is I have a newborn baby. He's 4 weeks old. And this is our first child. So we are really, really in the trenches on this one. And I barely know what day it is. I'm on parental leave. The baby's sleeping in a 90-minute burst, so are we. So if I see him a little bit out of sorts, for those of you who have parents or, are parents yourself, I think you'll understand where I'm coming from. If you don't have a point of personal reference for that experience, it's amazing and it is also pretty insane. So I am not necessarily firing on all four cylinders this evening. The second alibi is that I actually don't really have any skiing experience. I've been skiing a couple of times. Um, I'm not a ski, and so I am, familiar with some of the challenges. But I really don't actually have a lot of firsthand experience with the environment. My specialization is in, I guess you could probably say, kind of general wilderness medicine. So here in Kentucky, um, I don't even think we have a ski resort. I think the closest one to us, the closest one to me personally, is Perfect North Slope in, I think, somewhere in the Indianapolis area. But we have woods and lakes and rivers and highest elevation is somewhere around I think 2,000, 3,000 feet, but what I specialize in is in cliff rescue in particular. So high angle rescue. We have an area here in Kentucky called the Red River Gorge, which is popular with rock climbers, and has just general backpacking and kind of trail-based activities. And so that's what I've come to specialize in addition to the helicopter rescue. But I think the applicability to the ski patrol environment is that, as is common in many wilderness rescue contexts, you don't have the ability necessarily, nor is it wise to be, getting your patient trauma and, hooking up lots of different diagnostic equipment and, taking a 35 pound, cardiac monitor defibrillator with you. Those things are just not reasonable, not practical, certainly in a old setting. We probably want to maintain the integrity of our patient's layers. And so all of this drives the need to get good at kind of low resource assessment and how to hone in on key problems with maybe less information, some could say, than we might otherwise enjoy in, a traditional setting like an ambulance or an emergency department or something along those lines. So that this topic or this presentation tonight is really about. And I know that there's a huge spectrum of experience and credentials in the audience. So some of you might find some of these points somewhat rudimentary. But one of the things that I have, sort of noticed time and again over the years of teaching professionally is there's usually somebody out there who could use a refresher on some basics. But also, you have to be the basics if we're going to be good at the fancy stuff and at the advanced stuff. So it's always worth, I think, doing a review of some of that basic information, even if you're sitting out there and you have decades of experience and dozens of letters after your name. So that's where we're going to begin. Let me pull it up and we will get right into it. All right. So we tested this earlier, this view that I've put up here. It works a little bit easier on mine as the presenter to just kind of have the whole PowerPoint window up. If you do have trouble seeing what's on the screen or things are looking crowded, drop a note in the chat, and I can change the view or whatever we need to do. Okay, so on the note of the basics, I teach in a baccalaureate paramedic program. So we have students that come in from EMT programs really all across the country. And we interview them for admission to what we call our advanced sequence. So if you come into the program with EMT certification, you get sort of a little bit of advanced, and you can skip over a lot of the freshman year courses that we would be making you take. But we interview you for your paramedic level of training. And so we're a fairly prominent university in the EMS education space. We get these students from EMT programs all over the country. And year after year, when we interview students, we ask them, can you define shock? And many of them cannot succinctly define shock. We get a lot of different answers about patients who are bleeding to death. Oh, it's a patient who has been injured really badly and they're dying, things like that. So let's just make sure that we all understand the basic definition of shock. And it is quite simply hypoperfusion to the organ systems. Regardless of the cause, right? There's a lot of different causes of shock, and there's subcategories of shock that you can put different etiologies into. But regardless of the cause or the why, it's important that we understand that this is really what we're talking about. We're talking about not enough oxygen, and some other sort of like life-sustaining kinds of nutrients and things like that, I guess you could say, getting to the organs. But really, we just don't have enough, primarily oxygen reaching the organs. That's really the primary issue, right? All right, so very, very simple, very concise definition of shock. Hypoperfusion or insufficient oxygenated blood to the major tissues of the body. So if you give this a Google, if you flip through a bunch of EMT textbooks, you'll find typically sort of like four broad categories of shock. You can slice and dice shock in a lot of different ways, and you can argue what specific etiologies or processes fit best in one of the boxes. But basically, most people, there's a kind of a consensus grouping into first hypovolemic shock. So this is going to be hypoperfusion anytime there's insufficient blood volume. So that could be something like hemorrhagic shock. Literally don't have enough, basically red blood cells circulating in your body. You've spilled them out onto the snow, or you have internal bleeding collecting somewhere. But this can also just be a depletion of the liquid content of what should be in your blood vessels. So it could be the plasma component. So you can experience hypovolemic shock from vomiting, from diarrhea, from dehydration, pathological dehydration kind of generally. So in other words, hemorrhagic shock is really just one type of hypovolemic shock. We have shock anytime the heart is basically unable to pump efficiently, pump well, and really, have that good forward pumping through the lungs to pick up oxygen, offload CO2, and do it again. Anytime that heart is weak or not beating well, we could have cardiogenic shock. So this includes a range of different things. Most cases I think we associate with cardiogenic shock in the kind of EMS environment is basically like congestive heart failure or heart attacks. But this could also be valvular dysfunction. This could be arrhythmias, whether they are sort of uh, hyperacute or something that needs more prolonged kind of care from a cardiologist. But arrhythmia causes this issue. Let's not forget about obstructive shock. And this is going to be any time that pumping of blood around the body is inhibited, and there can be sort of physiological problems, or there could be mechanical problems. And so this includes things like a pulmonary embolism, where there's essentially a clot, blocking perfusion in the lung tissue. All right, so we can't pick up oxygen, can't offload CO2. It includes things like tension pneumos, where pressure or is building up inside the chest cavity, squeezing down on the great vessels, the vena cava, the aorta a little bit, and really inhibiting filling of the heart in addition to pumping of the heart. And one thing I always want to make sure people understand about obstructive shock is you can induce obstructive shock with overzealous bag valve mass ventilations. Right? If we don't pay really close attention to the rate that we're ventilating that patient and the volume that we're putting into that patient, we can really start like stacking up breaths, increasing the pressure in the chest cavity pretty substantially, really drive down blood pressure, and really inducing an obstructive shock state. So that BVM is, kind of a dangerous tool in the untrained or non-judicious hands. So I think that's important to note and to talk about. And there's other examples of all these different, categories of shock. We go on and on about each one. The last major category is distributive shock. And so this is really about blood volume, typically plasma, leaking from blood vessels or blood vessels that don't have sufficient tone to be able to sustain blood pressure. So you'll see a little asterisk on the screen for sepsis. Sepsis is actually the cause of shock overall in the medical literature in the United States. And it has a high mortality rate. So when you look at all the different, reasons that people are in shock, when you do these huge studies of EMS records and hospital records and so forth, it's sepsis, not trauma. But sepsis, is an example of this. And then specifically for trauma that might be germane to the ski environment, something like a spinal cord injury, where the patient cannot really, transmit or regulate signals along the spinal cord. The body is essentially going to sort of relax into this sort of like default, sort of like basal life-sustaining state where the blood vessels just kind of dilate. Respiratory rate can get, irregular. But the body is unable to sort of reflexively maintain tone in the blood vessels as a result of that spinal cord injury. And so that's a form of distributive shock. So again, you could I mean, I could do an entire presentation on each one of these slides, and we could go super deep into every single one of these quick examples that I mentioned, every single one of these categories. But that is not really what this presentation is about. This presentation is about more so recognition that your patient is in shock, and then some simple ways that we can hone in on that in an austere setting, and some tools that can help us sort of get ahead of this. Um,
It's
but regardless of the cause of the shock, there's some signs and symptoms. Again, just a quick review for people.
Dave. I'm sorry, Dave.
Yep,
Wanted to interrupt one quick second.
sure.
We do have a comment that someone would like you to go into the slide view, if you don't mind.
Got it. Okay, yeah, yeah, let me do it.
Just go slideshow. Yep, got it.
Uh, slideshow. Yep, just give me a second.
Yeah, play from current slide. Yep,
Yep,
there. All right,
this
thanks.
better?
Got it.
Okay. Um, okay. So there's a few more or less common signs and symptoms that are categories of shock. And this is not exhaustive either. And there can be some big differences as you get into specific kinds of shock. So, for example, as a general rule of thumb, in most of your shock states, heart rate would increase. That is not necessarily true in something like neurological or neurogenic shock. But as a rule of thumb, these are these common signs and symptoms that we want to start to key in on as we're assessing our patient to see whether or not they might be in shock. What we are going to unpack a little bit here is, why do some of these things occur, and what is it really telling us about what's going on, and what do we have to anticipate and think about in patients for the best outcomes? And
We do
okay,
we do have one question in the chat regarding septic shock and
yeah.
explain more about septic shock, actually.
Yeah. Okay. So, septic shock is a shock state resulting from a systemic infection in the body. There can be many causes of that, but think, anything that could cause infection could, progress to the condition that we call sepsis, which is, basically clinical evidence of widespread infection throughout the entire body, sort of propagated through the circulatory system. And so, one of the things that happens in sepsis is widespread inflammation. And in all these, in most of these different shock states, not necessarily all of them, I was about to say, but kind of in most of them, one of the biggest culprits is that the lining of the vasculature starts to get inflamed and starts to basically break down, get kind of leaky, and your blood vessels go from being these sort of like relatively tight, smooth muscle tubes to being something that think normal vasculature is like a garden hose, and inflamed vasculature maybe like layers of cheesecloth, leak out of them once the vasculature becomes inflamed. And so with sepsis, is that that lining, the glycocalyx, becomes kind of inflamed, kind of unstable, kind of leaky, and you can have fluid that basically is leaking, out of the walls of the vasculature, rather than being contained in the vasculature and being pumped around, effectively and efficiently and acting as it should. There's a couple of other things going on with sepsis as well, but that's kind of the broad strokes for why you could most logically put it in the distributive shock category. The one of the problems with sepsis is that the kind of the fluid component of your blood it's it should be in your blood vessels in a different space in the body than those blood vessels. So does that answer that question?
We do have one question around how that sepsis patient might present in a cold environment.
Mm, yeah, that's a good question. So it does get me thinking that there's actually, there's like two kinds of sepsis, so to speak. There's like cold sepsis and hot sepsis, and if there's like a raging infection with crazy fever, it's hear that referred to as like hot sepsis or warm sepsis. And then there can be sort of like less obvious sepsis that doesn't necessarily have that like crazy temperature or showing up on your assessment, so-called like cold sepsis. But I think generally in a cold environment, if you were to, for some reason, encounter a patient like this on the slopes, I think it'd be pretty hard to pick up on, to be honest with you. I think that they're generally here to be probably just like hypothermic in general. They don't have great circulation. They're sick. They're experiencing this sort of like physiological insult. They're probably not going to be able to warm themselves and thermoregulate very well, and they'll probably appear to you as just sort of like sick and cold. If their extremities are kind of exposed or if they're not getting great circulation to those extremities, you'd probably still see the same sort of like peripheral vasoconstriction kinds of stuff that you might expect in a lot of different kinds of basically environmental. Um, to be honest with you, this is one of those things where I lacking the ski patrol experience. I'm not sure. My instinct is to say you probably are not going to encounter a sepsis patient in that setting. Somebody who's at the point of sepsis is probably not going to be feeling like, hitting the fresh pow. They're probably going to be pretty sick at home or maybe, on their way to the hospital. But there are some situations that, I mean, I've experienced just as a, paramedic otherwise where patients are sicker than they realize, and they are trying to sustain their normal routine or they're on a planned trip and they don't want to be the bummer, who ruins the ski day or whatever. So they try to trudge out there and then they, kind of essentially collapse, out there. So I don't think it's common. I don't think it's likely that you would encounter a sepsis patient as a ski patroller. But I suppose it is possible. My hunch is that it would be hard for you to pick up on the sepsis specifically, just given the environment that you're encountering that patient in. So I don't know, Linda, obviously from a hospital-based background, sepsis is a huge issue, and you see a lot of sepsis patients, and you are an actual ski patroller. So
Yep.
what do you think?
So honestly, in this particular case, I doubt this person's going to be able to tolerate skiing or snowboarding. They're
Hmm.
going to be too sick at this point. It could potentially be grandma who's sitting in the lodge, who might be out watching as, the kids are skiing, and she drug herself over there, but is looking bad sick. Although that's even fairly unlikely, but I think that this is good to know because we're also people who have neighbors, who have family members,
Hmm.
who may experience sepsis.
And where you had
And
the
and yeah, we're emergency care providers, so we need to understand
Yeah.
what sepsis looks like. But it is a really good question, and oftentimes the patroller may be the one in the family who has the most medical knowledge,
Yeah.
and they may be approached.
Yeah. I will say real quick again, I haven't encountered any patients on the slopes myself, but in this area that I cover, the Red River Gorge out here, we get like 1 million visitors a year. It probably should be a national park. It's not. It's a National Forest Service property, but it's very heavily, enjoyed by the public, and people bring all of their comorbidities with them into that environment, right? So if they were going to have a heart attack, today, they're having it out on the trail. I've had patients who got on that cardiac note, for example. I've had patients who got released from cardiac rehab and thought that maybe it might be a good idea. Now it's time to maybe start hiking again or something like that. And they're out there and now they're basically in like frank congestive heart failure, in the middle of the woods. So there can be some unexpected presentations like that where, you could certainly be saying to yourself, I would not have thought that this person would be in an outdoor recreation situation, but stranger things have happened. And then the example that Linda gave of the like a grandma back at the lodge, I think that's a great one too. We have rental cabins all over this area. The family is out there hiking and rock climbing and paddling, and yeah, somebody is back at the cabin, a little bit older, a little bit less physically conditioned. They brought him along on the trip. They booked a cabin for Thanksgiving or something like that. And there is grandma back at the house, basically battling pneumonia. And she is getting sicker and sicker over the few days. And then a 911 call gets placed. Kind of we're out here in this, rural recreation area, and we do have a septic patient, because of this infection. So it's good questions.
They
And
are. Someone even said an employee. Someone doesn't want to
yeah,
miss work, right? And
yeah,
they want to lose the money, lose the pay.
yep,
Uh,
yep,
so absolutely.
yeah.
Urinary tract infection too is a big
Oh
one.
yeah, yeah, big one for sure. Big one. Big cause of sepsis. Um, okay, so again, some patterns that we tend to see in many forms of shock. And there are some nuances and some differences, but this is kind of the center of the Venn diagram for the most part in most of these shock states. It's also worth recalling that there are stages of shock. And the first stage is often called compensated shock. Some people call it pre-shock, but I don't really like that term. It's really compensated shock, and so we have this fundamental problem of insufficient perfusion to the tissues. Oxygenated blood is not going where it should in enough quantity or quality for whatever reason, and in most cases the patient is going to basically try to compensate for that. And the primary mechanism of that compensation is basically going to be catecholamines, these chemicals that your body produces from the adrenaline out of the adrenal gland, for example, to try to stimulate things like increased heart rate to try to move a little bit more blood around the body, increased respiratory rate to try to get more oxygen in with each sort of respiratory cycle, and try to clamp down on muscle tone in those blood vessels to try to sustain blood pressure. So those catecholamine hormones and chemicals, help to do that on a normal basis. So your body's going to try to pump out maybe a few more of those. And that is really the explanation for why you see this classic sort of cluster of signs and symptoms in most of these conditions. If you take just the most simple version of what I just laid out, and that is kind of basically like adrenaline or epinephrine being kind of squirted out, it makes perfect sense why these patients have an increased heart rate, increased respiratory rate, can be a little clammy, a little bit diaphoretic, a little bit of sweat on their skin. Uh, they can feel anxious. That anxiety can be a comp of that sort of increased heart rate, increased respiratory rate, jitteriness kind of thing. Um, Going where it should, like to the brain. And then pale skin because again that adrenaline, epinephrine, norepinephrine, these other kinds of chemicals and hormones are causing peripheral vasoconstriction to try to sort of shunt blood to the core vital organs. And so, think of how somebody looks when they kind of like get on a treadmill. You're seeing a fight or flight reaction from those catecholamines kind of surging with the body trying to compensate for the shock that they're experiencing. But that cannot be sustained for a very long time. The body can, go into sort of like a decatecholaminization where they're really running out of those hormones. They're not able to produce enough, or maybe they could keep chugging along, and that adrenal gland, could just keep cranking out, hormones all day long. But the patient's just lost too much blood, or the spinal injury is just too severe, or whatever the shock state is, whatever the cause is, it really just is too much for them to be able to compensate for. And so that is when you would slide into this decompensated phase, the stage two. And what's important to understand about this is that that is really when you would start to see something like low blood pressure, hypotension, which we usually define for adolescents and adults as a systolic blood pressure of about 90 or lower. Um, to get to that point, usually your patient would need to have lost about 30% of their circulating blood volume. Now, that's not the only cause of hypotension, right? There can be other things in the mix. You can also have patients who, really do just have a very low kind of resting blood pressure. So like with everything, there's always sort of little outliers on things, but kind of in the center of the bell curve, I guess, of information. If I have a patient who, for example, is injured, and I'm suspecting basically blood loss. If their blood pressure is, about 90 systolic or less, I really want to be understanding that this patient's probably lost a really significant amount of their blood volume, about a third of their circulating blood volume. So, the problem with this is that, I mean, I've been an EM long, long time, been a paramedic instructor for a long time. The textbooks, the training that we all tend to get, right? Oh, if my patient has less, it's shock. But that's a relatively late finding, and we want to be able to pick up on some of these shock conditions, much earlier than that, so that we can intervene in whatever way is appropriate practice or our protocols. So if you are an advanced, you might have a huge arsenal of things that you could do for these patients. You might be able to give them TXA, tranexamic acid, to stabilize blood clots to help promote, stasis of that bleeding or staunching of that bleeding internally. You might be able to give vasopressor drugs to help those blood pressure, or I'm sorry, those blood vessels clamp down and help that glycocalyx stabilize. You might be able to do all kinds of things. If you have a more sort of BLS scope of practice, you really might be limited to simple things like keeping the patient warm, giving them oxygen, uh, but recognition of the shock and prediction of their clinical course, and then making smart decisions about things like evacuation, method of evacuation. Are we going to be calling for an ambulance or a helicopter? Are we going to be calling for additional resources, like ALS resources to come help us? Those things alone, which are, very basic, are life-saving. They're critical. And so we want to try to get ahead of this recognition curve, and pick up on some of these earlier findings, so that our patient doesn't sort of slide into this stage three or irreversible shock, which is basically going to be, widespread cellular death, and it's called irreversible because it's literally irreversible, right? If we sort of cross a threshold physiologically, the patient is not going to survive, right? So the name of the game here is trying to recognize the things that are likely to cause shock, the patients who are in an early shock state, so that we can intervene appropriately as early as possible. All right. So this we're getting out of the basic review slides for those who keyed in on the shock index and some of the fancier stuff in the description. We're getting there pretty quickly. But this is why it is so important to have a structured assessment process. And, experienced providers can sometimes be terrible about this. The experience is a double-edged sword, right? It gives you pattern recognition. It gives you recognition prime decision making. It gives you the ability to say, man, I know what I'm looking at here. I can let's rock and roll. But it also means that sometimes we develop kind of the bad habits of not doing a nice, thorough, organized assessment and missing some things, getting some sort of some blinders on. And so I think that is even more true in kind of an austere setting where, there can be a lot of distractions. There can be a lot of challenges in scene management, operating sort of in a nice flow. Again, my thing is like the woods, just, trees and rocks and sticks and cliffs. And man, when you're over the edge of a cliff in the middle of the night in August, and you're sweating through your clothes because of the hike out to the patient. You just had to rappel over the edge of an 80-foot cliff to reach your patient. You got your headlamp on, and there's all kinds of bugs in your face, and a giant wolf spider crawling across my thigh. I mean, it can be difficult to stay focused. And so, using the structured assessment process that we get taught in basic, EMT class, basic wilderness first aid type training is really actually pretty important. So you might have been taught various frameworks for doing that. The two most common, I think, are what you see on the screen, the ABCDE with the little X before it for exsanguination or bleeding out onto the ground or onto the soil or whatever. But ABCDE is kind of the traditional Department of Transportation style curriculum. In the military community and wilderness medicine community, it's a little bit more and it's basically all the same thing. It means all the same stuff, slightly different terminology, maybe in some cases a slightly different ordering. But it's what is going to kill the patient first, right? Let's be very mindful of assessing each one of these things to be able to get a good grip on is our patient, as we say in Kentucky, fixing to die on us, right here, right? So, these frameworks are not just for novices, is kind of the point that I'm making here. They're going to help us pick up on some of these important findings. All right, so this is a picture used with permission of a patient that I had many, many years ago. This was how I found the patient when I reached him in a situation basically just like I described to you. August, middle of the night. This was about 2 o'clock in the morning. Got the call for a 80-foot cliff fall. And when I rappelled down to him and reached him, I found him exactly like this. So mostly lay search and rescue volunteers had gotten him exposed, had done some basic first aid, had gotten him into this sort of harness you see. It's has a lot of different names out on the market depending on who's making it, but it's basically sort of like a diaper style harness that you can see just kind of wraps around him. Because the idea was they were just going to pull him up the cliff, right? Like they were thinking this is not a patient who we need to put in like a litter and keep supine. We're just going to put him in this sort of hasty harness, take him right back up the cliff. Somebody had tried to make, I think, a pelvic binder of sorts out of that red material. Um, and that this is what I found. And this picture I took was, I think, a still from basically like, my GoPro. Um, a little bit of helpful information here, I think, is that this is being illuminated by one or two headlamps, right? So, um, but anyway, hot, sticky August night, middle of the night. So I want to open it up quickly. You can, I don't know, Larry or Linda might have to do a little bit of moderating here, but I'll pose some questions to the group. Um, what is your general impression of this patient? In other words, do you think that this patient, as you lay your eyes on him, is critical, not so critical? Are there any obvious life threats? So that's kind of question number one. And the other one you can take a stab at is what problems do you see?
Mhm. So I'm seeing AVPU, position is worrying.
Mhm. Okay.
Given the mechanism of injury, I'd say critical.
Okay. Yeah.
Was he alert, David?
He was. Yeah, he was alert.
Seeing pelvic injury. Did the
Yeah,
patient actually fall from the cliff? That's a good question.
it is a good question. Yeah, so this patient was alert. He was mostly oriented. He was a little drunk. So the reason he fell off this cliff, you can actually Google man sleepwalk 80-foot cliff, Kentucky, and you'll see a Good Morning America interview with me in the aftermath of this. This guy had a history of sleepwalking, set his hammock up at the edge of an 80-foot cliff, and sleptwalked himself, 80 feet down to the earth. And so he again, this is a user's permission, and he's a very cool individual who's happy to support education through his story. He had a couple around the campfire, very common, at a campsite with some friends. And so he was, a little disoriented to the extent that he had been sleepwalking, so that kind of you affects your awareness, I guess, a little bit. Wasn't quite sure exactly what the sequence of events was that got him into this predicament. Had a couple of beers. I don't know that he was drunk per se, but anyway, he was not totally sure exactly what was going on, but was generally plugged in and was certainly alert. So if that blue circle wasn't there, eyes open, tracking what's going on, conversing mostly lucidly with the rescuers. So someone mentioned,
Dave,
he's critical.
there's it's just a couple people commenting that the head
Mhm.
on the rock is concerning, that his chest cavity looks expanded or there's some
Mhm.
protrusion, and
Yep.
they're asking what his breathing was like and his ABCs.
Yeah, excellent. These are all excellent questions, and this is exactly where I'm going with this slide. So all of those things are ways that we can very quickly start to hone in on, is this patient likely to be shocky or not shocky? So one thing I want to kind of mention real quick though is that mechanism of injury in and of itself is actually not a great predictor of criticality. It used to be emphasized really, really heavily. If you look at the more recent edition of the American College of Surgeons Field Trauma Triage Guide, mechanism itself has basically been sort of de-emphasized in favor of essentially objective assessment findings. What is the patient's blood pressure? What is their respiratory rate? What is their heart rate? What is their skin condition? And the reason for that is because of things like this. This guy fell 80 feet off a cliff, landed in the position you basically see him in now. Yeah, his head was kind of, up against the rocks and everything. His only injury was a chipped T8 vertebral process. Right, basically just a little chip off the little, nub on the back of your spine. No other significant injuries. And things like this happen all day long throughout the country, right? Throughout the world. You know, surprising kind of variables can get plugged into the mix to make something that looks really serious not so critical. And so in this case, one of those factors was the soil that he's laying on is incredibly thick and spongy. It's basically feet worth of decaying plant matter, and it's called loam. Just this really fluffy soil. You can actually basically post hole like up to your knees through the soil in some of these spots at the bottom of these. So for one thing, he kind of landed on this giant, natural. But one of the things that you see here, though, if we just kind of zoom out a little bit, you don't have all the information, obviously, and it's hard to tell what's going on with a still from a helmet cam. But one thing we want to point out here is, his skin condition's actually pretty good. He has like a farmer's tan, right? So he's a little bit darker around his neckline and his face, and you can kind of see on his forearms and then down below his knees, he's a little bit more, and his thighs and torso and everything are a little bit more pale. But he's not like diffusely pale, right? It's not like he's pale all over. It's not like he's looking gray or dusky or anything like that. I don't see any obvious external bleeding. I don't see any obvious sort of like swelling to like his thighs or his abdomen. I don't see kind of like a chunk in his chest where his ribs are moving in the opposite direction from the rest of his rib cage, flail section or anything like that. So I don't see any major bleeding. I see a patient who looks mostly pink in the places that he should be, and I have a patient who's alert. And those are all signs that he's probably not in shock. Now, I can't leave it at that. I need to continue my assessment. I need to collect some more information. But this initial contact with my patient, I can glean a lot of information. And this pops up in EMS teaching all over the place. And one of the places it pops up all the time, and then we sort of fail in some ways, I think, to extrapolate it to other situations, is if you take the Pediatric Advanced Life Support course, or PALS, you learn the Pediatric Assessment Triangle, the PAT. And this was on my mind as I was doing this presentation because we were just teaching PALS in my program at EKU this week. And the idea is a really sick baby. They can't communicate, they can't vocalize. So you have to observe them to see whether they're. And so the three elements of the pediatric assessment triangle is what you see on the screen: overall appearance, breathing, circulation to the skin. And there's some kids, so if you are not, super plugged into pediatric care, one of the things, for example, that's like somewhat specific to kids, adults can do it too, but things like covering of their nostrils. All different who are in respiratory distress might flare their nostrils to try to tidal volume, but kids do this readily when they're kind of in respiratory distress because they favor breathing through their nose. So there's little things like that are, you could say are kind of somewhat specific to kids, but the general idea of this thing is just as applicable to adults, adolescents, any age group as it is to a tiny baby. We can take a quick look and, be mindful of what we're really looking at in terms of appearance, work of breathing, circulation to the skin, and we can apply that to a patient just like this, and we can come to a pretty evidence-based conclusion, to be honest with you. In this patient is probably not critical. There's a caveat there, right? In this moment, and probably, but it can start to kind of frame, what we're going to do next and how we're going to proceed through this. And that's pretty helpful. All right, so there's some pretty good evidence behind this for all these different age groups, and that's what we're going to kind of get into right now. So there's kind of three key vital signs that I always am very, very mindful of. Skin condition and mental status is wrapped around all of this, right? So let me just say that one more time. Skin condition and mental status. So by skin condition, I mean, are they pink, warm, and dry? Are they looking really like pale and gray and, maybe a little, cyanosis or those things? So skin condition and mental status wrapped around this whole thing. But zooming in just a little bit more, here's three vital signs that start to change readily when our patient is even just in the compensated shock state. So we can try to hone in on this really carefully. And then as we go through the slides tonight, we're going to get into how we can put these together into some different scoring tools to be able to give us a pretty good sense of where our patient's head. All right, so the first one is pulse pressure. And this is the difference between the systolic and the diastolic pulse readings. Right, so your normal textbook adult with a blood pressure 120 over 80, it's very simple, right? 120 minus 80 gives us a pulse pressure of 40 millimeters of mercury. Right, so this starts to really quickly, actually, if our patients are trying to compensate for shock. And to help explain that, there's a couple of different formulas we're wrapping our mind around. And actually, let's look at the bottom one first, maybe. So CO stands for cardiac output text. So that's how much your heart is literally pumping around. And that is going to be a function of your heart rate and then the stroke volume. How much liquid blood is basically being pumped out with each beat of your heart, right? So how much liquid are we shooting out and how fast are we shooting it around? That is your cardiac output. And then your blood pressure is really a function of that, the cardiac output, times systemic vascular resistance or SVR. And systemic vascular resistance is the tone in all of those like distal vessels in the tips of your fingers and your skin and kind of all the um, uh, end points basically of your circulation. Systemic vascular resistance affects all your blood vessels, but when your body is trying to basically maintain blood pressure, it's first going to start to clamp down smaller, more distal blood vessels easier. It can squirt out some of those catecholamines, clamp down on those smaller vessels a lot easier than it can like clamp down on something like your aorta, for example, right? So that's where it's kind of most salient, right? So we have cardiac output, we have the tone in our smaller blood vessels, and that is really what is basically producing blood pressure, right? So blood pressure is quantity of blood in those vessels, the cardiac output, and then it's also how much tone and how much pressure is kind of squeezing on the pipes. And so, again, there's that formula. Blood pressure is cardiac output times SVR. And if we plug in some variables here, let's take our like prototypical textbook classic patient with that nice, perfect adult blood pressure of 120 over 80. They're probably going to average a cardiac output of about 5.25 liters. So basically every minute, that's how much blood volume is going to be circulating. And that can slide around a little bit. Larger people, more blood volume, smaller people, less blood volume. That number can fluctuate for some other variables as well, but we're talking kind of an average here, right? Average adult of like average proportions and quarter liters of blood volume. And systemic vascular resistance can be measured, like in an ICU. They can put probes in your heart, in your blood vessels, to actually measure truly how much pressure is being exerted in those areas. And so, most people, unless you're like an ICU nurse or like a cardiovascular nurse or something, you're probably not walking around with the normal SVR range memorized. It is part of like critical care paramedic knowledge, but most people aren't walking around with this. So just as like a reference, like 900 dynes per second per centimeter would be a fairly average SVR reading. All right. So here's your normal vitals, if you will. And then your patient gets injured. They ski into a tree and they shatter their pelvis and they crunch up a bunch of ribs and they lacerate an organ like a liver or a spleen or a kidney or something like that. And they're losing blood. That blood is pooling in their abdominal cavity. And so we, therefore, in this example, have lost a liter of circulating blood. Again, it's pooling in the abdominal cavity, and they are, and so the body is going to try to squirt out some of those hormones to maintain or improve that blood vessels, probably trying to shunt some blood from the skin and from less important tissues for survival to those vital organs. Let's make sure that we're trying to send as much blood to the lungs, to the brain, to the heart itself, alive. So we have a decrease in one of those variables. We have a compensatory, increase in the other variable. But the thing is, you've still lost actual volume. And so there just isn't as much blood as there should be circulating. And so the blood pressure is just going to get a little soft. Yeah, our bodies, at least initially, are probably able to down a little bit, on those blood vessels through, those hormones and dopamine and some kinds of, chemicals like that to try to improve that tone of those blood vessels. But we just, it's just not as good as kind of the normal homeostasis of having enough blood to begin with. And so you see the blood pressure is a little bit soft, but you also see that pulse pressure is narrowed, right? The two numbers are closer together because for the vigorous pump on the systolic side, right, that heart squeezing, pushing blood out, we really just don't have as much as we should. So cardiac output is diminished. And the diastolic, that is where, that's about relaxation of some of that vascularity. And that's where the body is trying to compensate in this situation with a little bit of those catecholamines. And so it is compensating, it is trying to maintain that tone. And so the diastolic reading is higher than it normally would be because the body's trying to clamp down in between those beats of the heart. And so this is very subtle, right? This is very, very subtle. You might not be able to pick up on this at all. You probably wouldn't be able to pick up on the first set of vital signs because, you don't know what the patient's normal baseline blood pressure is. And so this is why trending your vital signs is really important. We want to take, two or three, rounds of vitals a few minutes apart and start to develop that baseline when we have a patient who has a mechanism of injury like what I described. So we can try to see, are there changes? Is that pulse pressure, starting to narrow? And then if they become, shockier, well, then we're going to kind of start to actually kind of move in the opposite direction where that blood pressure is going to start to kind of widen out again a little bit more just as we have less blood circulating and less of an ability to compensate. But, in the initial, several minutes of patient contact, you really might be able to pick up on this narrowing pulse pressure. And it's one of the earliest changes. And this is borne out in the literature of studying thousands and thousands and thousands of shock patients all over the world. Pulse pressure is one of the earliest things that starts to change. All right. So then the next one is respiratory rate. And this one has some really uh, kind of like stunning evidence behind it. So the with the literature, again, looking at like patient populations all over the world, really tells us is that if a patient is sick, if a patient is injured, significantly injured, a respiratory rate greater than 20 is associated with um, kind of like bad outcomes, increased adverse events, just basically being a sicker patient. And stunningly, really, in my opinion, a respiratory rate greater than 25 in those same kinds of patients. So we're talking about patients who basically like they are sick, they are badly injured. We know those things already. If they have a respiratory rate greater than 25, like a sustained respiratory rate greater than 25, that is an independent predictor of mortality. Okay, so if you encounter your patient out on the slopes and they've been busted up pretty badly, and you're at their side for, 10, 15 minutes or so, working the scene, assessing them, collecting vitals, if they're breathing at like 25 a minute, or greater for, kind of a sustained, period, that's a critical patient, even if they're not obviously critical otherwise, right? So, for example, my patient at the bottom of the cliff, when I had been down there with him, and if his respiratory rate had been, basically north of 20, especially north of 25 over, a few rounds of assessment, um, that could really justify the need to do something like a helicopter hoist rescue in the middle of the night. Or can we maybe get some blood products here to the scene over the edge of this cliff, while we rig a system to raise them up or something like that, right? That's where this information starts to become valuable, is that it starts to help you predict really the criticality and therefore the clinical course of your patient. And I'll do kind of one more real quick, and then it might be a good time for a break. Yep. Okay. And so I cannot speak for other health professions, but I can speak for EMS. We are terrible about this, especially if you are used to working on an ambulance in your day job. I know for most people, ski patrol is a additional activity or a volunteer activity, but we are terrible about this as EMTs and paramedics on the ambulance. It really you can see like this is a meme that I pulled from Facebook from the Savage Paramedics Facebook page. That is how bad we are at it, is that people are making memes about this, right? So we tend to kind of like eyeball our patient. We're like, oh yeah, that looks like it looks like about 16 respirations a minute. And, let me chart that. And well, I can't put that again, or else it'll look like I'm not counting the respiration. So my next entry on my chart is going to be like 18 breaths a minute, right? And I can't see everybody's faces, but I know that there are some EMTs and paramedics out there on this chat nodding their heads right now. So the point is, let's actually count respirations. Let's actually count them. And I'll show you some tools that we can use to do this really, really easily without having to, spend a 30-second cycle, actually manually counting respirations, which is an important skill to know, but there's some tools that can help us do it a lot better. All right, so with that being said, let's take a quick break and then we'll keep on rolling when we get back.
All right. Larry said WNL, we within normal limits, or we
Yeah,
never looked, right?
yeah, exactly,
Yeah,
exactly.
yeah. So,
All right. So it is 8:34. We'll take a 10-minute break and be back at 8:44. If you
Yep.
have not completed the attendance log, please do. I'll put the link back in chat, and I'll also post the QR code. Otherwise, enjoy your break, and we'll see you in a few minutes.
Yeah, we will get off to the races in the second half for sure.
David, I know there was a comment earlier when we were still all the comments about sepsis,
Hmm.
and somebody asked about how fast does.
It was just heart rate. And that's again, I know very, 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 very basic for a lot of people, but just again, quick review here. Again, cardiac output, heart rate times stroke volume. So if we lose some circulating stroke volume because we're in shock, what's the variable that our body is going to try to manipulate to basically like maintain homeostasis? It's going to be that heart rate. So that is achieved through that release of those catecholamines to increase heart rate. All right, so we have these three, very, very basic vital signs, but there's a little bit more physiology behind it than you might have been aware of. And we're going to use these now for some a little bit more sophisticated, but really, really helpful kind of like clinical decision-making rules. They're not truly clinical decision-making rules for I know that there's some people in the audience who spend a lot of time in the research space. So is I'm probably belaboring this point because I'm a little bit of an academic, myself, but let's just dive right into it. Um, okay. The first one is shock index. The official name of this is Algoer's shock index. Martin Algoer was the guy who basically came up with this a long time ago, actually. And it really only recently made its way into common understanding by at least the EMS system. Yeah, I'm not sure if it caught on earlier than that in some other healthcare settings, but for EMS, we really did not get into shock index until like kind of the last 5 or 6 years, to be honest with you. Even though this information's been out there for a long, long time in the literature. Shock index, or SI, is a really, really simple formula. Heart rate divided by systolic blood pressure. So, in other words, the only tools that you need to be able to calculate a shock index is a blood pressure cuff and your fingers, right? I can take a bi-palp blood pressure to get a systolic blood pressure rate. I don't need a stethoscope. I can wrap that blood pressure cuff around my patient's arm or leg. I can locate the pulse point with my fingers, pump up that blood pressure cuff, basically see where that or kind of note where that pulse point falls away. Lock, pump up the cuff, reduce the pressure, and when that needle, as it comes back down the gauge, when I feel that pulse return, that is the systolic blood pressure, right? So all I need is a blood pressure cuff and my fingers, and of course I can get a heart rate by palpating pulses as well. And so if I do some very quick kind of simple math, you might have to pull out a phone to do this. That's fine. Divide heart rate by blood pressure, and what you get is this, result. And basically, what shock index tells us is that if it's greater than zero point 0.8, the patient is probably in shock. Now, the thing is that in a lot of your shock patients, you'll probably be able to figure that out pretty in shock, right? They've suffered a significant injury or they appear to be pretty ill, and they look bad and they're feeling weak and fatigued, and maybe they've even lost peripheral pulses. You see blood everywhere. I mean, there's a lot of clues where, in many cases you're going to be able to say to yourself, yeah, yeah, this patient's pretty wrecked, right? But where this becomes really handy is a couple of things. The first is, again, settings that we are in as wilderness professionals, where we actually have the ability to do that great, thorough, take all the clothes off, get them under bright lights, hook up these different cables and monitors and get all these different readings, right? Sometimes it is almost all we can do to get the most basic set of vital signs. And so then being able to sort of uh, quantify this information into kind of a useful predictive score can be really, really helpful, because think about the entire rest of the rescue. Kind of like I mentioned earlier, how many resources are we going to bring to bear for this patient? Evacuation strategies going to be? What other resources I need to maybe call to the scene? And how do I justify that? Because we know that mechanism alone is actually not really a great predictor of severity. So the shock index score can be used in lots of different ways. It tells us a lot of different things. Maybe on the BLS side of the house, it can help us key in on that the patient is likely in shock, even if we have not been able to detect that through collection of those other vital signs. But we grab the heart rate, we grab the blood pressure, and oh man, that number is greater than zero point 0.8. Maybe I need to focus my mental framework here a little bit more and find out why that is. And let's, maybe change gears just a little bit in our assessment. So in other words, it can kind of be a cognitive reminder, or light bulb that comes on that there's something more going on here. Let's kind of go to the other end of the care spectrum, to the ALS level and something like intubation. One of the things that shock index can help us predict is the difficulty of an intubation from a physiological standpoint. We always want to try to resuscitate before we intubate. But if I'm assessing my patient and I'm preparing for intubation and they have a very high shock index, it means that, or really not very high, just an elevated shock index, it tells me as the paramedic, I need to have a really good plan for something like push dose pressors. Maybe I want to have somebody working on calculating a drip of the pressor that I'm going to hang on the other side of this intubation. Maybe I actually don't want to intubate this person at all. Maybe their shock index is really high, and I'm just really concerned they're not going to survive the intubation, like the RSI. And so maybe that's not the strategy that I want to employ on the side of a hill, in the middle of the woods, bottom of a cliff, next to a tree well that we just pulled somebody out of. I'd have RSI'd them had I been in a little bit of environment, but this is not necessarily the time and the place. Let me opt for maybe a less invasive airway strategy right now, because their shock index is telling me if I proceed with this intubation, they are probably going to have a negative outcome. Shock index predict things like how many units of blood are they likely to need. The higher the shock index, the more blood that the patient probably is going to need. Now, you may not have blood available to you in your system, but that alone is again a predictor of, what's our next move here? Like, what's the destination we want to move this patient to? What method of transport, and so on and so forth are we going to choose here? So the shock index is, basically it is a clinical prediction tool for how bad off is this patient and how likely are they to have a really negative outcome kind of clinical course over the next few minutes and several hours. So this is just a quick, you look at these numbers and they're not necessarily screaming at you that your patient is critical. I mean, somebody who's exerting themselves, right? And a blood pressure of 107 over 80 is maybe good, maybe bad. I don't know the patient's baseline. I have no other information about this patient, right? All you get is two numbers. 105 divided by 107 gives you a shock index of 0.95. Okay, so shock index is not a slam dunk, right? Because again, we don't have the rest of the picture. So this could be somebody who has a perfectly normal blood pressure and perfectly normal heart rate for them for the activity that they've been engaged in. But you see the value of the information that you might not have picked up on those numbers being a problem because they don't scream crazy, blinking red lights with those numbers. Those could easily be, again, normal vitals for that patient, right? But if we actually run the numbers and then we do plug in some context, like they've been injured or, they are otherwise kind of ill, that's a fairly high shock index of 0.95. So the value of the shock index is that it helps us hone in on, oh man, there might be something more to the physiological story here. And again, this patient is less likely to do well, more likely to do poorly with procedures like intubation, RSI, extended evacuation times, extended transport times, those kinds of things. And so, how do we gear our strategies from this point forward, given this information? So again, this is not new in medicine. I think it's actually been longer than 52 years at this point. I think I might have made this slide originally several years ago, but basically, yeah, at least 52 years ago, Martin Algor, established all of this in the literature, and for some reason, it took a long time to make it out there to the EMTs and paramedics of the world. Right. Another really important shock indicator to understand is mean arterial pressure, or MAP. Now, this formula is a little bit more complicated, but it's easy to memorize if you just commit yourself to it. Make some flashcards, write it on the mirror and lipstick or something, look at it every morning when you're shaving or whatever. Systolic plus 2 times the diastolic divided by 3. Right? So systolic blood pressure reading plus 2 times the diastolic blood pressure, and then divide that by 3. So for this, you would need a blood pressure cuff and a stethoscope or a blood pressure machine to get that diastolic reading. But what we're looking for here is a result greater than 65. So if the result of my calculation is 65 or higher, basically not in shock because they're not hypo. If it's 65 or less, then yeah, they're and this is really important because this is the difference hypoperfusion and hypotension. Hypotension is a lower than normal blood pressure, but that's not the same thing as hypoperfusion, right? Here's an example of this here's our formula, systolic blood pressure plus 2 times the diastolic divided by 3. Again, we're looking for something basically 65 or higher to be probably okay, and 65 or less is not okay. And so if I plug in this blood pressure here, it is hypotensive, but it is not technically, hypoperfusion. I mean, it really kind of is because, if you think about a normal blood pressure and plug it into that formula, a normal map is going to be somewhere in the range of the 90s. So a map of 70, kind of in of itself, I'm definitely suspicious of. That's why I'm putting it in yellow.
Yeah.
Yep. Is that a question or just Okay. So that's why I kind of put the map in yellow. But again, it helps us distinguish between, like, is this person's like normal blood pressure for some reason? Like, is it And this is especially helpful when we start to think about differences in blood pressure, um, at different age groups and things like that, right? So mean arterial pressure, we want to see basically 65 or higher. The closer we are to 65, the more shocky they are. 65 and below, they are very much in shock. And it means that they're not compensating if they're, 65 or less. Their body is not able to address that insult. If you're using a cardiac monitor, it's important to understand that the machine is acting and backwards conversion into a systolic over diastolic that you see on the screen. So this is a LifePak 15 view. I know there's like LifePak 35 out there now. But basically, in the corner of the blood pressure box on your cardiac monitors, if you have that available to you, maybe now we're back in the ski clinic, that's where you're going to find the map level in that bottom corner. And then on something like a Zoll or a ProPak MD, it looks more like this. And again, that is your map in parentheses there. And so again, you can see on this patient, this is a good example of the difference between hypotension per se and hypoperfusion. This person has a map 11 points higher basically than you know, that critical threshold of 65. So it doesn't mean that they're not maybe still sick. There might be something else going on. But again, it helps us kind of hone in and kind of guide our decision-making process. And it's a data point that helps us understand where our patient really falls on that spectrum of criticality. Now, there's also the modified shock index, and this is actually much more precise than the standard shock index. It's just a little bit more challenging, maybe, to work with in kind of a high stress, low resource environment. You're doing a lot of like manual calculations. But the modified shock index is we first calculate the map. Okay, so we first have to run that little formula of systolic plus 2 times the diastolic divided by 3. Okay, then I get my heart rate, and I divide heart rate by map. The reason that the modifier is actually more precise is that it accounts for the diastolic blood pressure. And that diastolic phase is, for example, when the heart fills its own vasculature, it gets its own blood supply during the diastolic phase. And so it's just an example of how by factoring in the diastolic variable, we actually get a more kind of like precise measurement that gives us a little bit of fidelity about how this patient's really doing shocky. On the standard shock index, it is it's like sensitive but not specific, right? So you could have like a elevated shock index reading and not actually be in shock. It's just, it's kind of, we have to correlate it with the rest of the patient picture. With the modified shock index, it's a little bit more, kind of specific of if they have an elevated MSI reading, yeah, they're probably pretty sick, right? And so if we have a MSI modified shock index of greater than about 0.13, and again, that patient is critical. They are shocky, even if you didn't realize it earlier. They are probably going to have a much more challenging clinical course. They're going to need to be evacuated sooner and faster, so on and so forth. There's another really cool concept out there, and we can do this in a relatively low-tech way. And this is called the pleth variability index. So pleth is short for plethysmograph, and that is the waveform that you'll get for perfusion itself. So again, in like the ICU type setting, they can put probes in all the different, parts of your body, and they can get a pleth measurement from like, whatever part of the body they want to measure. Where we are getting pleth indexes or pleth tracings in EMS is basically fingertip SpO2 probes. And, it just gives you a waveform that basically tells you about perfusion out to the little tip of your finger. So distal perfusion. And we can use that to kind of figure out like how vigorously and how strong is the heart beating and how much perfusion is making it out to the fingers. And by looking at the variability in that waveform, you can actually derive a reading that gives you a sense of how shocked your patient is. Now, of course, a caveat on this, right? We're putting a probe on our patient's fingertip. If those fingers are cold, snow, winter, ski patrol, right, that can interfere with the accuracy of a SpO2 reading. And if the patient is already shocky enough that they don't have good distal perfusion, that can really alter your SpO2 reading overall. But if the fingers can basically be warm to some degree, or are not super cold, if they are again kind of in that earlier phase of shock and we're trying to pick up on it, this can be helpful. So, if you look at like a cardiac monitor, you could be able to pick up on this just by taking a second to kind of scrutinize the SpO2 waveform over the course of a few seconds of the cycle and just look at the difference, look at those smaller pleth spikes compared to those larger ones ahead of it. The simulator that I'm using to generate this doesn't let me do a variability index, so I had to generate this image of like high perfusion on the front end, and then I switched it to low perfusion where the pink arrows are, and then I took the screenshot. But you might be able to get the idea from this that, again, variability, if the crests on those SpO2 pleth waveform are not uniform, that is indicative of a perfusion problem, or could be, I should say. And then the other thing is just if the amplitude is low, like what you see beneath the pink arrows, if the amplitude of the pleth waveform is low, that could mean that they're in shock, representative of poor distal perfusion. Could also mean that their fingers are really cold. It could also mean that your SpO2 probe has slipped off their finger a little bit. So SpO2 is, don't necessarily take it to the bank, but it's another data point that we can use to guide our ongoing assessment and ongoing monitoring of the patient. So what's really cool is that there is a couple of devices on the market that do calculate this. So this one is called the Masimo MightySat. Um, it's a little expensive. They pop up on eBay sometimes for $150, $200. But one thing that they give you is if you look down here, they give you a pleth variability index calculation. And basically, the literature says that if the pleth variability index is greater than 19, it's sort of like that shock index calculation. It's possible that your patient's in shock. So we have to put it in context, put it in the clinical picture. We're not going to chase the rabbit of just the PVI number, but we're going to put it in context and it adds to that clinical picture. So, again, my world, my case example from this slide presentation, I'm at the bottom of a cliff with a guy who fell 80 feet. I slipped my SpO2 fingertip probe that, has a waveform display and it's looking not so great. It's a low amplitude or there's a lot of variability. So I double check it. Is it seated correctly? Is his finger clean? Is his fingernail, clean? Um, yes, it is. And I have reason to believe it's getting a good rating. So, for example, or good reading, and he has a distal pulse, that sort of thing. Oh, hey, I'm picking up here on early shock state, and I want to maybe re-gear my decision making based on that information. This device also has this thing called the pleth index, and it has its own scale. And there's emerging literature about the pleth index being useful as a predictor of some things, but beyond what I'm intending to talk about. So, okay. Another thing that's really helpful is NTO2. Now, I know that this is not available to everybody in all scopes and all practice settings. Here in Kentucky, end-tidal CO2 was not available, was not in the scope of practice for EMTs until about 6 years ago. And we had to fight a relatively hard battle to get it added to the EMT scope, for diagnostic purposes, I should say. So uh, you may have seen this out in the field, but basically there's two different kinds of sensors that you can put on your patient. Yeah, pardon me, you have what's called an inline sensor that you see on the left, where we can put it on top of a tube, in between a mask and a bag of a bag valve mask, so on and so forth. And then you have nasal cannula style end-tidal CO2 sensors that have, they look different than a normal nasal cannula. They have two tubes coming off of them instead of just the one for oxygen. So one goes to the oxygen cylinder, one goes into a cardiac monitor. But pardon me, I got a little frog in my throat there. These are collecting carbon dioxide readings from our patient's exhaled breath. And this is what a normal end-tidal CO2 waveform looks like. It's a replicating sort of plateau of a shape, and there's a normal amount of 35 to 45, and that is true across all age groups, and actually is true across almost all mammals. So this is used in veterinary medicine as well. I'm pretty confident in mammals because I've taken a dive into that. It might also be true for other organisms, but essentially it's like more or less like the Krebs cycle of basic cellular respiration when functioning normally is going to produce an end-tidal CO2 of 35 to 45 for sure in humans. Right, and so that's the normal range of end-tidal CO2. And so if you're not familiar with this, for some of you, again, this is like this is old hat. You're using end-tidal CO2 all the time, every patient, every day. But if you're a little bit newer to this is extremely valuable information. You can use end-tidal CO2 values, so that number of 35 to 45 or beyond, and you can use the morphology of that waveform, the visual appearance of that waveform, to derive a huge range of information about your patient. We use it to measure the quality of CPR. We use it to determine if our patients have gotten return of spontaneous circulation. We can use it as an indicator of sepsis. We can use it as an indicator of why is our patient wheezing? Is it that their bronchioles are actually constricting and spasming, or is it that there's just swelling of the tissues basically in the airway for some other reason? So I could go on and on about this. It's another thing I could do an entire 2 hours just on end-tidal CO2 and barely scratch the surface. All right, so if you're not familiar with end-tidal CO2, it's a very cool thing to get into and learn about. It's very, very valuable. And we can use it to look at our patient's shock state. I'll skip over, I won't get too far into this, but basically this is just what it's measuring. The baseline is actually the patient inhaling, and then the upsloping shape is the exhalation of that carbon dioxide rising out of their airway basically and being collected by the sensor. And so the thing about it is that, you know, again, it's basically a product of cellular respiration. And so if cellular respiration is healthy and normal, in other words, the patient's getting enough oxygenated blood, and that blood is pumping around the body efficiently to be able to exhale the CO2 on the other side, you'll see that normal waveform and normal value. But if they're in shock, if they're not getting good oxygen delivered to their tissues, if they're not getting good blood flow throughout their body to be able to collect that CO2 and then take it back to the lungs, you're going to see some changes. And it might look like something like this. As you look at several breaths across a pattern of breathing and a period of analysis over a minute or so, you might start to see some issues like, man, my end-tidal CO2 is low. We've done several cycles of breathing, and we're not getting a good level here. I'm expecting this to be 35 to 45, and it's not. It's 30. And so why is my patient who's laying in the snow, why did I have a decreased end-tidal CO2? It could be because they're breathing too fast, and they're blowing off more of that end-tidal CO2 than normal because they have been exerting themselves. They were skiing or snowboarding or whatever. And after a couple more minutes of laying here, their respiratory rate should normalize. and their end tidal CO2 levels should return to normal. But what if they're not? What if we're laying here in the snow? We've been laying here, and our respiratory rate is not slowing down. Oh, and I remember from that presentation about this that elevated respiratory rate in a patient who's been injured or has some underlying illness is not a good sign. And it looks like their end tidal CO2 level is less than normal, less than 35 to 45. Why are they not producing enough CO2? Well, it's basically, I like to think of it as basically the smoke off a campfire. You know, that campfire is the cell and its cellular respiration, right? Like literally producing like body heat, in the aggregate. Okay, so that's your little molecular campfire. And for that fire to be nice and warm and putting off like a nice smoke, I guess, you have to have a good fuel source and you have to have, the right conditions for that fire. If you start giving it real nasty fuel, you're going to get real nasty smoke. If you start choking off the oxygen supply, the whole fire is going to go down and you're not really going to get a whole lot of product out of that campfire. And so that could be the reason. Again, it helps you kind of key in on, oh man, we're starting to have these data points here stack up. And I haven't even had to do a whole lot of assessing. We haven't undressed our patient. We haven't, done a head to toe exam or anything like that. But I put an end tidal sensor on their face and I see a less than normal end tidal CO2 reading, less than essentially. And I see a decrease. And especially if I was looking at this over time, over the course of several minutes, I started to see it trend down. That would be a potential off to shock. So in a hospital, we're getting end-tidal readings off of big, cumbersome, heavy machines that cost, $45,000. But this device is worth its weight in gold. This is called the EMMA. And the one on the left is, I don't know if it's actually sold anymore. It was the version that did not have a waveform. But this is just a graphic I found of, the two different models for the size comparison. But the one on the right is what you can get these days from a variety of different vendors. And you can see the size. And this, again, fits right on top of a breathing tube, fits right on top of a mask for BVM. And it gives you that end tidal reading, that level, the quantitative number there is 39. So nice middle ground, 35 to 45, right in the middle. We see a respiratory rate of 13. And then you see a waveform at the bottom that can be analyzed for the morphology to give us all the information we want. So these retail for somewhere in the neighborhood of like $1,700, but you can find them much cheaper than that from like biomedical refurbishing companies. And you can use them in lots of different ways. And again, there's like a million uses of end tidal CO2. We use it to confirm our airways, confirm that our endotracheal tubes are placed correctly, confirm all kinds of stuff. But on the left there, you can see that you can take a end tidal and pop it into a nasal airway, put your EMMA on a nasal airway to get a reading. You can see some other pictures here of ways to adapt it to different devices. And basically, they've just had to take tape and, tape things up to get it to fit, because none of this is designed to like fit together in these particular ways. The EMMA is designed to fit on top of a endotracheal tube is what it's designed for. This is a picture of a patient from the gorge. And you can see that we adapted our EMMA up into basically a non-rebreather mask. We pulled out the reservoir and we put this thing up into it. This was a patient who did not need supplemental oxygenation. His pulse oximetry was fine, but we could not rouse him. He was an overdose patient. He went up to a high point in the gorge, like climbed up on top of some rocks, basically. Got high, keeled over, smashed his face. So there's a little bit of a bloody nose there. And he fortunately was with friends who called for help. And so that was his big problem was like basically like a polypharm kind of overdose. In other words, like he had a lot of substances in whatever like mixed together is what he kind of got high on. So we couldn't rouse him. So we wanted to monitor his airway while we carried him out. So we, used the Emma to do that and make sure that he was still breathing and still breathing well. What's kind of funny about this picture is that this was a Emma that we bought used and it's in the measurement is kilopascals instead of millimeters of mercury. So for the one guy on this webinar from New Zealand, you can probably interpret this readily in kilopascals. But for those of us here in the U.S. Medical community, we had to type up a conversion chart of kilopascals to millimeters of mercury to put in the case, with the EMMA, but we got a screaming deal on this device. So anyway, that's what you're seeing there. So 4.3 would be a grossly insufficient end tidal reading in millimeters mercury, but in kilopascals, it's just fine. All
David,
right, we're gonna.
I'm sorry, there's a question about
Yeah.
whether Narcan was used or not on him.
Yes, Narcan was used on the basis of altered mental status and pinpoint pupils. So, first we started ventilating him. Then we um, got the Narcan aboard. He basically the substance that he took, he bought from an individual. It came in a dropper bottle, and he did like a couple of drops of it on his tongue, according to his friend. And so it was probably a mixture of several substances. So the Narcan was given, as indicated, but it did not rouse him. Presumably addressed the narcotic or the opioid in his bloodstream, but whatever else was in that, uh, concoction. So that's why at this point he really didn't need significant oxygenation. His respiratory rate and effort returned to normal, but he was just unresponsive for hours while we carried him out. So our primary goal here was just to be able to monitor his breathing, because your patients are all trundled up in layers of, this was a chilly time of year. You can see we have a Mylar rescue blanket. SAR team initially placed some like a trash bag warming type, stuff on him, which was a smart move. But anyway, he's all bundled up. You don't have a great sense of chest fall and that. It's also just hard to monitor your patients analog while you're carrying them out in a Stokes basket along a trail. So putting a mask on him to be able to adapt the Emma up into it allows us to just look right down and see, yep, he's breathing. Yep, he has a normal respiratory rate. Yep, he has a good waveform, good end tidal CO2. And then, of course, check a fingertip pulse ox every once in a while to make sure he's still oxygenating. And that was our primary intent with this setup. Okay, so first things out as we kind of hit the 9:30 hour here. How do we actually treat some? Well, if there's one thing that I really want to hone in on, one thing, all the different, whiz bang interventions that we could possibly do, blood plot product replacement, say, and pressors and drips, but best things you can do for a shock patient in general, but especially your trauma shock patients, hemorrhagic shock patients, spinal cord trauma patients, is keep them warm. So many of you have seen this before. If you haven't, the trauma triad has three legs: hypothermia, acidosis, and coagulopathies or problems with blood clotting. And the thing about this is that all three of these elements are, and the one that we can hone in on and basically address the most effectively in most cases in the wilderness is going to be hypothermia. Literally just keeping your patients warm can save their life. And I'm not talking about environmental hypothermia, right? Like it's not because of the snow on the slope. It's that a trauma patient whose body drops below 98.6 Fahrenheit is in trouble physiologically. Okay, so this is not actually environmental hypothermia. This is really like um, physiologically like trauma-induced hypothermia because of things like poor circulation of blood because of the shock state. So if you're on the slopes, then yeah, for sure you got to keep your patient and think about is not probably pumping blood around real well. They're probably having some issues with clotting, so blood is kind of leak out of whatever kind of have occurred, and so they get cold. And I just mentioned all that, so I'll actually keep on moving for the sake of time. But what the literature tells us is if a trauma patient's body temperature drops 3 degrees Fahrenheit from 98.6, their mortality risk triples. So you can extrapolate that a little bit to basically sort of think of it as for every degree that their body temperature drops, their mortality risk is going to go up 100%, 100%, 100%. It's not literally that way in the literature, but you kind of get the idea, right? So just think about it in these terms. 3-degree drop in body temp, 3 times the mortality risk. So we really want to focus on keeping these patients warm. And we need to basically, be like really mindful and thorough about that. And this is just a good example of how important this is. This was a screenshot I grabbed off Facebook several years ago because it just struck me. 90 degrees Fahrenheit in the middle of June in Kentucky. Here's a flight crew taking a pretty bad head trauma patient out of a critical access hospital, and they basically have this patient in a sleeping bag. They're not totally bundled up. We got some feet sticking out, but that's kind of a visual reminder of how important it is to keep our critical patients warm because they have a really hard time regulating their body temperature and it's going to increase their mortality. And there's a cool reason for this. This is the, no pun intended, a cool reason. This is the oxygen hemoglobin dissociation curve. And so the red line is the relationship between how much oxygen is on your red blood cells on the left, and then on the bottom, how much of that oxygen is actually making it basically into your tissues. And you see that curve, and what that curve basically bears out is that if you're at a 90% SpO2 and you draw over and then drop down, you'll basically land somewhere in the like 80% range of oxygen actually making it to your tissues, which is just about right, just about correct. But basically, this curve shifts around with these variables. So I think of this as your hemoglobin, your red blood cell is like a school bus. And when we have, for example, a right shift, like your body becomes acidic, um, oxygen molecules don't want to get on the bus. They're just kind of floating around the bloodstream, but they don't want to necessarily uh, attach to the red blood cells as readily. They don't want to get on the school bus, if you will. But look at the left shift, lower temperature, lower body temperature. That is an interesting problem where the oxygen molecules will attach to the red blood cells pretty readily. They'll get on the bus, but they don't want to get off the bus. They don't want to move into the tissues. So when our body temperature drops, the oxygen molecules don't want to get off the warm school bus and get back out in the cold. They want to stay in the warm school bus. So that is really kind of like the, again, like kind of the pathophys explanation for why it's so important to keep your trauma patients warm, and your shock patients is what we're talking about here, warm, and why the mortality increases if we don't do a good job of that. All right, so to wrap up, oh, go ahead.
Yeah, there's a question. There's a couple questions in the chat. One is you had mentioned that there were some tips to grab a respiratory rate. So what are they? And number two, there was a comment around, particularly with like end-tidal CO2 or other tools that you're demonstrating, from the ski patrol standpoint. You've got a patient on the hill. Would you be using these tools, or would your goal be to try to get them off the hill? And I think
Yeah.
we're in a different setting where if we can get them off the hill and get ALS on the way, then obviously that's your priority. But you're also talking about austere settings
Yep.
where maybe you're deciding whether to do a long line helicopter, right? Or,
Hour
in
extrication.
hour extrication, and it's
Yeah.
sort of making resource decisions. And I think that's a key point. I just wanted to point out because it was mentioned.
Yeah, yeah. So I was just going to end on these two slides of just like another visual of the shock index and the map, and that's it. So
That's fine.
let me answer those questions. Yeah, so basically how to easy ways to get a respiratory rate. It's several different tools, but one of the ones is we're talking about low resource assessment here, but that doesn't mean that you can't use technology, right? So it's probably worth the investment to buy something like an EMMA device, and use it, and grab that. It's getting your respiratory rate for you. You can look down on that screen, see your respiratory rate. It's going to be accurate, and it's one less thing we have to count and calculate and stop, and look at our count on our sweep hand and our watch to figure out the respiratory rate. So I know that might sound kind of counterintuitive or kind of ironic, but that is one of the tips, I guess, is that sometimes little devices like that can give you, especially with an EMMA, such rich information about your patient, if you know how to interpret it, are well worth the money. And again, you don't have to spend $1,700 MSRP on it. You can hunt around, you can get them biomedically engineered, certified, refurbished for much cheaper than that. So that would be one thing. And then the second thing is just think about the algebra, basically, right? If my patient's taking a breath in and out once every 2 seconds, no, 3 seconds, once every 3 seconds or faster, they're probably critical until proven otherwise, right? So I don't necessarily have to do the whole count for 30 seconds and multiply times two, or the trick of, feel a pulse and then rest their wrist on their chest, or, I don't necessarily have to do those things. I can observe the respiratory rate for a few seconds. And if it seems like they're taking a breath quicker than every 3 seconds, then, again, we're above 20, and there's a pretty good literature base that in and of itself is associated with a sick patient who's probably pretty critical.
There's a question
Um,
around
yep.
how to spell Emma.
Yeah, it's a capital EMMA.
Emma.
Yep,
Just like
Emma.
the name. Okay.
Yep, common spelling. Yep.
Thank
And then there was a second question about do we want to stay and assess, and
Yeah.
judgment calls, to be honest with you. I mean, in general, the idea is get to definitive care, right? Like in general, movement is medicine. The thing though is that there are so many interventions where taking a few minutes to do them correctly to stabilize the problem is going to pay off over the longer term of that encounter. So again, it may seem counterintuitive to say, actually, we're going to stop, we're going to, like stay and play, if you will, with a really critical patient. But doing some things like, stabilizing fractures and stabilizing a pelvis, getting a good ventilatory strategy, warming them. Those have a big impact on your patient. And so doing those things can make a lot of sense. And if you have things in your scope or in your arsenal like the TXA, like whole blood, those things are definitely worth stopping to do, because therapies like that have a pretty good literature base that the earlier you initiate them, the higher the benefit for the patient is. So does it shave off 3 to 5 minutes to set up blood and get it hung and blah 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 and do all the assessment aspects of that? Maybe it does. Like maybe it should not take more than 5 minutes. I would. But does it take you 5 minutes to do that? Yes. But the earlier you give the blood to a critical trauma patient, the better their outcome. So, there's a matrix of basically of decision making, and you have to understand what the ingredients of that matrix are to Christian. Better to move, better to stay, so.
Absolutely. Yeah, thank you for responding to that. And there were a couple of other comments. One said, my agency has a backpack in the truck for when we have to hike in. If we can't fit it, we aren't bringing it. That means we also have to carry the monitor because otherwise we would have no pulse ox or any monitoring devices besides BP cuff.
Yep.
D is our friend if available in these situations. You have more hands than we might, as it literally could be just me and my partner hiking in.
Yep.
Advice when it's just the two of us.
Yeah, so that is this is what wilderness EMS is in a nutshell. So different tools, different techniques, different mentalities to how we pack gear versus, on the ambulance. And that's kind of why it's a specialty in among other things. We do not have a lot of hands on most of the responses we go on. In fact, most of the time on our Red Star responses, the team that I run, we are single rescuers. Most of the time when I'm sent down the hoist cable on a helicopter, I'm a single rescuer. And it is the same thing. It's only what we can fit. And so we're not typically bringing a life pack or a Zoll, into the woods or down a hoist cable. We are bringing we're bringing a device called VSM, Wilderness Vital Signs, a wireless monitor that has a 3-lead ECG capability. You can also get a version that has a full 12-lead capability. We're not bringing, the ability to do electrical pacing or cardioversion. We're bringing pharmacological pacing or cardioversion type drugs with us for those kinds of scenarios, right? So you do, if you're dependent on this is how we stock our gear for essentially the urban environment, and now we have to hike it into the woods, it's going to be really challenging. And so that's where the idea of specialized EMS, specialties, special gear, special equipment for these wilderness settings makes a huge difference. So that you can basically try to get as close as possible to what you would be using on the ambulance, and kind of adapt to this new setting where bringing all that stuff just isn't realistic.
And there is a question regarding recommendations for basic equipment to keep in a day pack for hiking, mountain biking, climbing. It
Hmm.
sounds like, when you're on your own and you just want your kit.
We might have to handle that one with an email follow-up. That's a longer conversation, I think. But I will just say that the kinds of courses that you have heard about, wilderness first aid courses and advanced wilderness life support course and that kind of stuff, those are great courses to take to learn how to stock a kit. But I think if we can grab your name or whatever, we can probably follow with a suggested list of equipment.
Yeah, we definitely can do that. And that actually would be a great topic for one of these presentations because there's a lot to that. And I think we could spend a good 2 hours on it. But thank you for asking that.
Yeah.
Other questions I see Eric has put out to please complete the post-workshop survey. And NSP has a great outdoor course, MTR, Mountain Travel and Rescue, agree. Um, and then thank you from the Giants Ridge Ski Patrol, excellent course. So getting some thank yous and a great session or good session and all of that. So and we've even got some recent NSP alumni on who are appreciating the opportunity to stay updated. So
Cool.
I will say that in Delaware, we are using shock index in our EMS units and we are doing statewide whole blood. So our paramedics are giving whole blood at the scene and they use the shock index as the indicator to administer that. So it is a big thing and something that we should all pay attention to. All right.
All right.
Anything?
Well, it was a pleasure. Thank you very much.
Thank you, Dave. If you just want to stay on with us just for a few more minutes, if the
Sure.
baby can wait a little bit longer.
Yeah.
Okay. We thank you all for attending and thank you for coming from all over the country. Really appreciate your being here
And New Zealand.
and New Zealand, and we put these out, pretty regularly. So stay tuned for the next Bear Creek EMS presentation, which we are in the process of planning. Eric, anything?
Nope, I'm good. I'm just gonna end recording. I know we had some technical issues earlier with Zoom. If if you do not receive a certificate from me in the next week or so, please reach out. I will make sure you get something to get credit for tonight. So, other than that, I'm good. Thank you all for attending and hope you have a great rest of the week.
Take good care.